This is Heart Rhythm TV, and I'm Dan Alyesh. Welcome back to the ICE Image of the Month. I'm joined today by a good friend here in town. I have Dr. Wendy Tzou, who's Director of Electrophysiology at the University of Colorado. Welcome.
Thanks, Dan. Honored to be here.
Thank you. And, our episode today is going to focus on, I always say with ICE, right? It's going to improve your efficacy and safety. It's going to improve your ability to identify the tissue and understand the anatomy. And really the meat of today's discussion is using ICE to monitor lesions for efficacy and safety, and really in some advanced ablation concepts. As a brief overview of our episode today, we'll talk a little bit about the evidence base for monitoring lesions with ICE and how it correlates to lesion size. Then we'll progress to some advanced ablation topics using hypotonic irrigant or half normal saline and using ICE to monitor lesions. We'll then proceed to bipolar ablation and using ICE to monitor lesions in that circumstance. Then ethanol ablation with, really gaining popularity in the atrium and the ventricle. We'll see how ICE can be used to monitor the lesion efficacy in that circumstance, and then conclude with some of the data that Dr. Tzou and colleagues have also done for understanding the risk of steam pop using ICE. So without further ado, we'll go to our first slide here. And comes from the Penn Group. This is a paper published in Echocardiography, going over a swine model, 31 lesions, where they looked at ICE changes or lesion changes on ICE, the edema that forms, the echo density, and the correlation with histologically with the size of ablation lesions. And I think they very, very adeptly pointed out that these ICE changes do correlate with lesion size. And so, it's a common practice amongst many circles to do this. And this is the evidence base for saying, hey, this does correlate with lesion size. The only issue I have with this paper would be that they probably flipped the ICE left and right, kind of like the way that Wendy does. Other than that, no, I think a great study. And Wendy, I'll have you comment on it as well too.
Yeah, no, this is one of several papers that have been published that have demonstrated the utility of ICE, not only for confirming where the catheter is located during RF ablation, but also in confirming greater efficacy with lesions that are achieved when using intracardiac echo compared to just fluoroscopy. So it's an important paper. The same group, as you know, have done a lot of research in this space, especially in that time frame, looking at just baseline ICE images and also looking to see whether or not abnormalities on ICE could correlate with substrate, and have also demonstrated that, particularly useful in the times when you can't clearly see substrate just on bipolar substrate or voltage mapping, as we have grown accustomed to do in structural heart diseases in particular.
Absolutely. Thank you very much.
And the right-left reversal, critical. I was trained at Penn, as I think many know, and I think it makes perfect sense. So I apologize for those who are not used to seeing that orientation, because most of these images will be in that orientation.
That's fine. I brought a mirror, actually. No. All right. So I'll let you take it away from here. Okay. Normal saline versus half normal saline.
Yeah. So that prior paper that you showed was a study of normal saline irrigant, which forever was, sort of the standard, and actually still is kind of the standard. Half normal saline was introduced as a modality to increase the depth and size of ablation lesions. And so this was really utilized in the context of tough VTs, tough ventricular substrate. And this is one of the first clinical cases in which we did this. You can see this is a patient who had non-ischemic cardiomyopathy VT, also prior cardiac surgery. On echo, you can see there that there is this stripe, and I alluded to this in the prior discussion, this hypoechogenic area extending kind of from the mid-myocardium to the epicardium on this inferiorly, in an area that would correlate with, when you look at the surface 12 lead of the clinical VT, with where you think the exit might be. And so what you're faced with immediately when you see this in the lab is, okay, this is going to be a tough case. in general because of the baseline history, but now I see this. How are we going to get to where we want to get with respect to substrate and depth of penetration with ablation with just the tools that we have? And so as proof of concept of the utility of ice, you can see that the first go around was with standard normal saline irrigant, pretty long lesions, titrating from 30 up to 50 watts. And with the higher powers, we would commonly start to get signs that were concerning for steam pop. And at the end, we were left with a lot of lesions, and you can see on the ice image there that you've got some depth of penetration there with the hyperechogenicity compared to baseline, but you can see that it doesn't quite reach to where that substrate is of potential interest. And in fact, the tissue there, when we're pacing at output that is not that high, still confirms that there's absence of electrical inexcitability. And on top of that, he's still inducible for the clinical VT. So we can't go epicardial easily in this patient because of the fact that he's had prior cardiac surgery. And so an easy sort of next solution that we tried, which was thought to be a little out there at the time, was to replace the irrigant with this heparinized half normal saline. And you can see here, look at the difference in the two ice images with respect to the depth of the lesions that you could estimate just based on the hyperechogenicity. And again, confirmed previously by the data from the Penn group as well as others. And proof in the pudding there is, of course, that once we do this, not only does it look brighter, but it no longer captures with high output pacing and no longer inducible. So just one example of how intracardiac echo can be useful, not only to monitor lesion efficacy, but also, to some extent safety. And we'll get into that a little bit later.
So a couple comments on your slide here. Number one, looking in the upper left-hand corner here. So those lesions that are on the cardo map there, those lesions there, are those all your normal saline or combined half normal and normal saline?
Those are all normal saline lesions.
So really a valiant effort.
Yes,
with
we
normal
did try.
saline.
Yeah.
So just kind of to summarize for the viewers, right? So half normal saline, the concept is Ohm's law. You're increasing the local impedance because of the hypotonic solution driving the power into the tissue. Is that a correct summary?
That's right, because the half normal has fewer ions and thus carries less charge. And so less capability for electric current, which RF is, to kind of conduct into that or be dispersed into that. And so then more is then driven, or it's like the path of least resistance is where things go. So the tissue in that setting has less resistance. And so the more energy tends to be driven that way. And this is work, that Will Sauer and Dewey Wynn really pioneered, with me kind of just assisting back in the day.
Absolutely.
Yeah, clinically shown to be very useful.
And are you defaulting to half normal saline in all your ventricular cases, or only specific substrates?
So in the setting of structural heart disease, and especially if it's a repeat ablation, yes. In the absence of structural heart disease, if it's pretty clear in my mind that it's going to be an intramural substrate, even if the EF is preserved, I will often default to that as the start. But for a first time idiopathic, I don't necessarily do this.
Well, thank you. And in my own experience, I think monitoring the lesions on ice is critical with this because you can see those ice changes very quickly. With hypotonic irrigant versus normal saline.
And actually, even with normal saline, sometimes you see it before you actually see the impedance change.
Oh, absolutely.
Yeah, so absolutely agree with you.
So now we'll just skip to our next topic. It looks like an LV summit ablation where you applied bipolar ablation. So I'll have you walk us through the slides. Yeah.
So I want to put the caveat in there. I don't typically do bipolar ablation for LV ostial or LV summit arrhythmias, unless there's a good reason. And the good reason usually is that I think it's safe. So it's like off the septum, it's a little bit more lateral, beyond that triangle that should be inaccessible. And also if I suspect it's like a deep intramural source. So in this case, we've got an ablation catheter that's positioned on the LV endo, kind of close to where, but a little bit more lateral to where the AMC would be. Yes, and then the other catheter that's on the epicardium here is actually contained within a large enough branch off of the coronary sinus or the great cardiac vein to facilitate an ablation catheter. So relatively unique circumstance on many counts here. But what I want to show is how useful ICE in this case is in terms of identifying the locations of the catheters. When you try to do this using many electroanatomic mapping systems, it is often difficult to see both catheters at the same time. I would say that there's perhaps one in which you can see both easily. But in the absence of that, you're stuck using fluoro. And in this case, one of the catheters is at least kind of pinned in position on the epicardium. In many cases, when we're talking about bipolar, it's on the septum. And then you're trying to negotiate holding both catheters steady, and you can only really reliably see one. Sometimes you can see two if you jerry-rig the system that is in a way that doesn't completely deconstruct cables. Then you're stuck kind of looking on ice, even with all of the above, or the scenario where you can see both catheters at the same time. You often are checking fluoro just to be sure, because you just never know. But ice is a very useful adjunct to making sure that the catheters are actually in the position that you want them to be, and that they're spaced appropriately far enough away from one another that you're not going to risk harm with creating too much energy delivery, or they're not so far away that you are basically functionally performing simultaneous unipolar ablation. So that's in this case, you can see the ICE markers. It's just under 20 millimeters, which is kind of like 15 to 20 is kind of the sweet spot for bipolar in terms of hoping to achieve a relatively transmural lesion. And this is the catheter positions at the start of ablation, so before any effective ablation has been delivered.
So, Wendy, I just wanted to comment a couple of things. First up, beautiful example. I think, we're used to applying bipolar ablation on the septum, but this is kind of, a unique circumstance and a really, really great example. Couple of things, the ability to see the catheter in the epicardial more position in the setting of coronary sinus. I think that, people always assume that you really can't see it. And we always do fall. I mean, I typically, even if I do see it, fall back on an angiogram. But I think, it is possible. And I think especially for monitoring your lesion on ice, it's very helpful. And so really, really cool that you can see both catheters in this circumstance.
I should also make the caveat that I did not ablate here until I confirmed that the epicardial catheter was at least 5 millimeters from the closest large branch, because that's an important. This is why this is an unusual example, because I don't usually apply bipolar in this setting. But it was a nice picture.
Absolutely.
Okay, so this example shows, after the completion of the lesion, I think you can make out here the pre and post, that there's a substantial lesion that forms that looks transmural, at least based on hyperechogenicity at the completion. So an example of how if you demonstrate safety and that the catheters are close enough in proximity to one another, but not too close, that you can still achieve success in targeting these intramural type substrates or sources.
And it's really amazing to see how the edema does stress transmurally in this circumstance, like it does many times with bipolar ablations. Question for you about active and passive catheter. What do you do in this circumstance?
That's a great question. And I have to admit, because, RF delivery emanates from both sides, both active and passive. And so, before I looked into this much, I thought that most of the current delivery was from the active catheter, that's where the larger size lesion would be. It's actually if the catheters are in close, or the electrodes are in close enough proximity to one another, there's an antenna effect that occurs, and you actually have active delivery from both catheters.
Okay.
And so I will sometimes, it depends on kind of limitations and impedance. And sometimes there can be a significant impedance mismatch, especially in this unusual case where I'm doing bipolar with one of the catheters within a very tight space, which inherently has a high impedance. And so it might be more feasible. It was, in fact, more feasible in this case to make the active catheter the one that had the lower baseline impedance to begin with.
Thank you. Thank you.
Yeah.
All right, so going on to our next slide, ethanol ablation definitely gaining a significant foothold in electrophysiology. We've seen the data from Vena Marshall, and then now another example, LV Summit, coronary sinus branches, ethanol ablation. Why don't you walk us through what you did?
Sure. So, I want to credit Miguel Valderrabano, who really pioneered this technique in the atrium and in the ventricle. And there have been, the incremental gain that has been achieved with ablation of tough arrhythmias from the atria as well as the ventricles in places where catheters can't reach really can't be understated. It's still an area of study, but I think it's an important advance. This is yet another LV Summit arrhythmia. And you can see here, what I wanted to really show with this left-sided image was that we had done extensive multipolar mapping. And this is kind of how this region of interest, which is in that area kind of by the AMC, how it looked at baseline. And then the subsequent image, so we've done standard unipolar ablation using half normal saline in this area, and still we're getting the PVC frequently. And this is kind of the hyperechogenicity that you see as ethanol is being injected into a branch off of a tiny branch into which we could only fit a microcatheter into which to infuse ethanol into this area, which we thought was relevant. And with that, we actually were able to achieve elimination of the PVC and the VT that was associated. So,
and again, I think we're, a great example here. Having done some of the Vena Marshall, it's pretty impressive. The ice changes that you see with alcohol infusion. There always is the question of, to what degree is it stunning versus, true durable lesion? And I think that, the LV Summit area actually, despite it being so vexing, is not huge as far as anatomic real estate. So clearly a great result here. Another question I have for you, this is maybe we're deviating a little bit, but well, first I'll say when you do your ethanol ablations, right? Are you watching the lesion always form on ice, and tell me what characteristics you see that you're monitoring, what pitfalls you're working through here?
I mean, honestly, I'm looking to see if at first, I've not done a ton of these. Miguel would probably be able to provide more insights about this specific question, but I wanted to see if we could see some sign of changes. And so the standard sort of advisement is to look on fluoro after you've injected the ethanol and inject contrast. And if you see staining, that's a sign that you've actually damaged, the intravascular network there, and then it's all kind of caught up in the tissue. And I wanted to see if we could also see it on ice, which this is one case, but we've subsequently seen it on many others. So I'd like to watch it as we're infusing, just to get an idea. I don't know if that specific lesion will translate into a durable lesion of comparable size. Again, Miguel has done some studies with MRI to sort of correlate that there is still a reasonably sized LGE that is identified on cardiac MRI post this type of procedure. I haven't done that yet to correlate with ICE, but I mean, I think this plus like the clinical result are kind of what I'm aiming for. Really, this is just to sort of use it as I do in the RF ablation sort of setting. To see that a lesion is effectively formed. And I've convinced myself that I think that that's real. Absolutely.
I think that, monitoring for safety, monitoring for size, it can be, and dosing, it can all be helpful.
I think too, I mean, if there's any worry about the, perforation that could be clinically significant in a small branch like this, which is unusual because it's intramural, but, you can monitor for effusion at this time too. Yeah.
So I'm going to take us on a little detour, just to say we've shown a couple LV Summit examples, right? And in my experience, I feel like LV Summit is not as rare as I would like it to be, and so high power, long duration ablation is something that I've also applied to this substrate, and I find that ice is critical because I find that sometimes there's a tissue priming in the initial RF that you can monitor for, that kind of echolucency as you titrate up to go with that high power, long duration. And I'll ask you, are you applying that technology and that technique, and are you using ice in that circumstance?
I mean, I think this is a substrate that, is challenging for all of us. And yes, I also think that we see it way more often than I would like. Yeah, absolutely. You start before we got to this point, we started with all the tools that we had, and that included RF applications in various formats. I used to do that. Once I became frustrated, I thought, okay, we should go with high power, long duration right away. What I found is that I often got steam pops because of that tissue prime, the absence of tissue priming effect, I guess. So I think a smarter approach, which one of my partners, Lohit Garg, along with Sanjay Dixit at Penn, published, was this concept of sort of priming the tissue from the beginning and sort of maintaining it for an even longer period of time. So using lower power but more sustained ablation. I think it was a paper by our group too, Dewey, when he was here, that showed that if you actually started with higher power at the beginning, you had a much larger impedance drop, and you were more likely to get steam pops than if you kind of started off slower. So that's kind of been the approach that I have adopted before going to these more alternative approaches. You do run into the limitation of creating a bunch of edema in a single procedure, in which case subsequent efforts with the same modality become more limited. And
Sure.
So it kind of depends on the patient and the context, the rapidity with which I progress to these alternatives.
Sure. Okay, so jumping to the heart of the matter, monitoring for steam pops. I'll say another caveat is that applying ice to all these different ablation technologies clearly has been valuable. And the future, by and large, one day will be a PFA-based ablation energy source, I believe. And the jury is out to see how we'll apply ice in that circumstance. I've played around with a little bit myself, but I'll take us back to monitoring for steam pops, monitoring for safety. You did some great work on this. Why don't you tell us a little bit about it?
Yeah, so this is just kind of an extension of other work that's been done, but just sort of quantifying the difference in the signal intensity over time. So the decrease in impedance rate, as well as the increase in the pixel intensity, was sort of associated with the pre-steam pop state. And so this is an example, obviously, of a steam pop on the top. And this is sort of how a good control lesion should look. Sorry, you could maybe fast forward. The one on the left is how a control lesion should look in terms of the impedance change. So as you apply tissue and you're desiccating it, the fluid kind of evaporates off or gets drawn off. And so that you get this decrease in impedance that's nice and slow. And that's kind of what you want to see. What you don't want to see is a really rapid drop in impedance over a very short period of time, which you can see in the initial part of the graph on the right. And then, subsequent fairly steep drop over time. And you continue that and you get what you get here, which is then a very sharp increase, very, very sharp increase, which correlates with then, marked increase in impedance due to lack of tissue contact introduced by gas that's, formed and basically interrupted the connection within the circuit. And so, Dewey and Will sort of quantify these echogenic changes based on pixel intensity in this publication. And as I mentioned earlier, sometimes you visually see these changes. You kind of get this spidey sense as you get used to looking at ice and have observed steam pops happening, when you actually need to stop before you're even seeing a change in the impedance that looks concerning.
Yeah, I agree. I think ice gives you, roughly a second in many circumstances where you start seeing the ice changes. You have a second to come up before, and you often haven't seen any impedance change. So a nice example of that, and also a nice illustration, kind of in a more scientific way, of how you can use all these tools to avoid steam pops. So thank you.
No problem. I agree with you. I think as PFA is introduced increasingly in clinical use, it'll be interesting to see. I think ice will still be important. It'll just, it will be interesting to see what sort of signs of efficacy and safety might develop with use of that energy source.
Absolutely. Well, thank you very much, Wendy, for joining us. And thank you all for watching Heart Rhythm TV.
Thank you, Dan.